This is where I practice now. I'm right at Jefferson in OBGYN. So we're a center with 2 physicians, 3 women's health NPs. We have a registered nurse on our team. We get referrals from all over the country. I think our average patient travels about an hour and a half to see us. And they're sent really when, the standard isn't working, the treatment isn't working, maybe the diagnosis is not adequate. So this is a, wonderfully challenging and also incredibly rewarding position that I have. I feel very lucky. So to begin, and I think this is an important reminder for all practicing clinicians, get an appropriate history. So don't just take the diagnosis for what it is, but really find out about the symptoms and how is that diagnosis arrived upon. Just because somebody has itching and discharge, it doesn't mean that it's yeast, right? And odor doesn't mean that they have bacterial vaginosis. And then also it's really important to find out how the treatment or the prescribed therapy made somebody feel. Did it help? Did it help for an hour? Was it a month of relief? Did things get worse? Did they not get better? So, that's always a clue that if things aren't responding the way you'd expect them to, then maybe it's time to go back to the drawing board. If that means, a different diagnosis, if that means a different treatment. So I always like to remind people of those things. So really we talk about symptoms and vulvovaginal symptoms in terms of these conditions. It's really important, I think, in at least the work that we do, to focus on, what are the symptoms? Forget what things look like, or forget, I have a yeast infection. Well, tell me about that. What are your symptoms? Because the way I could describe a yeast infection versus, 5 people in the audience could be totally different, right? And if we're not speaking the same language about what the symptoms are, then that already makes things really a challenge. So these are the kinds of symptoms the language that we use so that we're all on the same page. Is this an acute thing? Has this been going on for a week? Has this been going on for 6 months? Is it worse? Worsening factors, aggravating, relieving factors, et cetera. And if you are finding relieving factors, how long does the relief last for? So these are just kind of general reminders and a framework for how we can move forward. So we always find out about, prior treatments, right? Were they antibiotics? Were they antifungals? Okay, it was prescribed to use twice a day, but did you use it once a week? Did you use it once a month, right? Because that really gives us a lot of information about, maybe clues as to why things aren't going as expected. And then, very much to reiterate, how did you respond to each treatment, if any? Okay, so this is something that complicates a lot of my life on a daily basis. I think the marketing industry for, soaps and products and sprays, gels, powders is incredible. I cannot tell you how many times a day I'm telling people, don't buy any of these things that are marketed to help, any over-the-counters and anti-burning products, or, boric acid with tea tree, just for the heck of it. These things, I think, make this a lot more complicated and maybe can even exacerbate the problem. This, I hope, sounds familiar, but, we usually start with just very, very basic lab tests. This is about the most important thing that I do on a daily basis, is a yeast culture. So statistically, you can actually only ever see a yeast infection or diagnose a yeast infection on microscopy 50% of the time. So, that's 50%. I mean, that's not that great, right? So we really generally do yeast cultures on folks. And not only will that tell us whether or not they have yeast, but also the species of yeast. There are 50 different species of yeast, and they don't all behave the same way. And so this is supremely helpful. The other thing that I would very much caution, because we have yeast cultures, so if you do a yeast culture, I mean, I think, that it's 99% effective in detecting yeast if it's there. So I always caution people, if you're not sure about whether or not somebody has a yeast infection, just make note of that, right? You wait for the yeast culture. You can always reach out, or you can say, I suspect that they have a yeast culture, or yeast infection rather, but I'll follow up with the culture. But, as soon as somebody diagnoses yeast, and especially over and over again, and then the yeast cultures are negative, that already, sends a red flag. So it's a really little thing that can make a huge difference. So vulvar anatomy, just to review, because I think this is helpful so that we're all on the same page. So we have an anatomic picture as well as a real-life human picture. Okay, so bacterial vaginosis, here, this is, where we can start. So this is, a recurrent condition, and it's very problematic, and we see a lot of bacterial vaginosis. We also see a lot of overdiagnosis with use of the send-out Aptima test, a firm test. If you're familiar with Amsel's criteria and you have good training and a great microscope, you really shouldn't be using the Aptima and the firm tests. I mean, if you look at the categories of, bacteria that they're looking for, it exists in the vagina. You would want it there. And so that can really get us into trouble when people have been diagnosed 8, 10 times, and it's only ever by send-out tests. And, sometimes the symptoms aren't even aligned with what we would expect to see in somebody with BV. So here's where we usually figure that by the time folks make it to us, they've been given a lifetime supply of Metrogel and metronidazole. And I'm sure you can imagine the scenario. So we usually jump right to oral clindamycin or even vaginal cream. I usually ask because folks tend to have a preference for oral meds versus vaginal. So I usually ask about what they prefer. We also recommend, if they are sexually active, to a barrier, so either condom, dental dam, and abstain from receiving oral sex for 3 months, just because it'll massively increase the chance that they'll have a recurrence. And then usually once we do one of those, the clindamycin treatments, and the next time they're back with BV, we start this pretty rigorous maintenance regimen. So it includes either Metrogel, and then, or if somebody's not into that idea, the metronidazole BID, boric acid, and Metrogel. One thing that I will stress is that with all of our visits and patients and follow-up, it's really, really important that folks come back into the office, usually about 6 weeks after starting initial treatment. And then if they're on a maintenance regimen, every 3 months is when we like to see them, because we want to make sure that it's working. And we want to make sure that there aren't any complications and that we're not sending them away with 6 months of meds and come to find out that 2 months into treatment, everything has gone haywire, right? And so I think by the time folks reach us, they're really happy to come back and to follow up and be told, hey, what you're doing is working really well. Keep up the good work. You don't have this condition or this infection today. So that's very gratifying. So BV, here's some findings on microscopy. So no leukocytes, but the clue cells, it's kind of this classic jaggedy border, granular appearance. I always think that it looks like somebody took a pepper shaker and just kind of sprinkled it on the microscope slide. So this is a really challenging condition that I think we see more and more of. So it's when people who are told that they have BV or told that they have an odor, they come and see us, and there's nothing there to our eyes. And this can get into a really challenging cycle of, well, I know I smell and my partner tells me that I smell, but you're telling me I don't have BV. What am I supposed to do? And it's a difficult conversation. And so here's some various interventions depending on, how troubled, I guess, the client is who, is seeking your help.